So the remainder of this disclosure and whatever else is left now, these aren't as intricate and complicated as some of the topics we've talked about so far in ethics, but they're still pretty big deals, and you want to make sure that you spend enough time to make sure you understand how this works, especially if you're coming from another country, right? If you're not someone who's accustomed to Western medical concepts, then you want to make sure you get all of this, because this is stuff that can often become difficult in a question if you are coming from some medical practice in the East. So disclosure, first thing, full disclosure. Patients have a right to know about their medical status, prognosis, and treatment options. You tell them everything. They have the legal right to obtain copies of their medical records within a specified time frame. A patient's family cannot require that a physician withhold information from the patient without the knowledge and consent of the patient. A physician should explore why the family member does not want the diagnosis revealed, but ultimately the patient should be told. A physician may withhold information through the therapeutic privilege area only if the patient requests not to be told, or in the rare and controversial case in which a physician determines that disclosure would cause severe and immediate harm to the patient. So we talked about this earlier in one of these videos for ethics as well, where you might have a really old man or woman, and they might have the diagnosis of some kind of terminal cancer, and their grandchild might come up to you and be like, hey, please don't tell my grandparent the bad news. It's not going to go too well. The immediate thing to do, which is always safe to do with almost all these ethics cases, is to ask why, right? So you ask the grandchild, why do you feel I shouldn't tell your grandparent what's wrong, right? And then it's up to you as a physician to figure out what you're going to do. Okay, and you go tell the patient. If the patient has been competent and of capable, well, he's competent, of course, because he's an adult, right? But if the patient has been of capacity this entire time, there's no reason not to tell the patient, right? Because if the patient didn't want to know, they would have told you by themselves. And the controversial case scenario where you're supposed to determine whether or not telling the patient is going to bring immediate harm, that's very difficult to teach. It's something you would have to decide and do on the question if you get something like that. On the right over here, they have signs of suspected child abuse and earlier potential signs of elder abuse and neglect. Just little things to know, right? So it's nice that they introduce these key fact things all of a sudden in random places. So make sure you take a good look at some of these, because if you don't know these things, then you can mess up these questions, right? So make sure you know what's happening. Potential signs of elder abuse, suspected signs of child abuse. These are all things that we've talked about before too. Like when we were doing dermatology, we saw child abuse and where the child had burns, right? Burns in weird places, and that's one way to see that, oh yeah, this is definitely child abuse. So make sure you know what's happening there. Next thing, medical errors. So physicians are obligated to inform patients of mistakes made in their medical treatment. It is not appropriate for a physician to blame another physician for a medical error without obtaining additional information from the original physician. Never in your practice should you really be like, oh, so it was that doctor's fault that this happened. No. It might be that doctor's fault that something happened, but you still there's no point in playing the blame game, right? That blame is not going to lead to anything. Leave it up to the insurance companies and the lawyers to reach out to everyone and find out who's to blame, if it comes down to that. But if you make a mistake, you should let your patient know, right? So something that can happen, for example, sometimes patients need to get injections in their eyes to prevent the development of more angiogenesis, right? So you give this VEGF inhibitor in their eye as an injection, and maybe when they came into the clinic, they had a sticker on the left eye, and they really needed the injection on the right eye, and you ended up giving the injection in the left eye, and then later realized that it was supposed to go in the right eye. You come back to the patient and you tell them, hey, I injected your left eye with VEGF. Nothing's going to happen. It's okay that I did that. That wasn't what I was supposed to do, so I made a mistake. At that point, they're going to acknowledge, oh, okay, well, that kind of sucks. I went through all this trouble. Not cool, doctor. You're going to apologize and you move on with life, right? Now, some mistakes can be far worse. Some mistakes can be much more consequential. At that point, you can't be scared of the fact that this patient might sue you. Like, of course, you'll be scared, but you still have to tell them, right? So you have to tell the patient what happened. If the cause of a specific error or series of errors is not known, the physician should communicate this with the family promptly and maintain contact with the patient as investigations reveal more facts. One of the largest contributors to medical error is failure to communicate during sign out and handoff processes. The best way to avoid communication breakdown is to implement a checklist, which is often the answer choice, a checklist for handoff. So what they're talking about here is that if I'm done for the day and I'm going home now, the doctor that's going to replace me in this emergency ward or whatever ward, I need to make sure I gave them everything correctly, right? If I give them the wrong information, then that doctor who replaced me will now make mistakes with some patient, and things are going to go bad, right? So very important to make sure that we get how that's happening. So mistakes do happen. Mistakes happen. Medical error is a real thing, and it's definitely scary. And in America, another thing besides privilege and selfishness is this is also a selfish act, this act of suing people, right? So sometimes suing is very important and very necessary, but suing a doctor for a medical error is often just done because it'll make you a lot of money, right? It could be a very benign medical error, or it could be a slightly serious medical error. And if it's a very serious medical error, by all means, of course, sue the doctor. But if the doctor made a mistake where it should have been avoided, it probably wasn't just his fault. It was probably a systematic error, right? And in step 1, you learn about those systematic errors that occur actually in healthcare delivery, or let me see. Yeah, the Swiss cheese model, right? So focuses on systems and conditions focuses on systems and conditions rather than an individual's error. The risk of a threat becoming a reality is mitigated by deferring layers and types of defenses. Patient's harm can occur despite multiple safeguards when the holes in the cheese line up. Right, so you have multiple defense strategies to make sure a mistake is not made. If a mistake is made, then you got to find out how all these defense lines missed it, and then you try to fill that hole in, right? So that next time it's not missed. But failures occur, mistakes happen, and you always have to make sure you disclose the mistake. Do not hide it, even if it was a very, very benign mistake. And there are step questions that would try to make you think, since the problem wasn't that big of a deal, we don't need to tell the patient. When is the problem not a big deal at all? Well, imagine a patient who needs to get 2 things done. They need to get their, let's just imagine, I can't make up a specific scenario, but let's say that there's a patient that needs process A and process B done, okay? And they only need it done on the left half of their body. You treated them and you ended up doing process A and B on both the left and the right side of the body. And then it just so happens that because you did it on the left and the right side, they are feeling great. Regardless, a mistake has been made, right? You made a medical error because you were only going to do it, or were only supposed to do it on one side, but you did it on both sides. It just so happens that you ended up helping the patient even better than anticipated, but you still have to disclose the fact that this happened. Okay, so even if your mistake actually ended up benefiting the patient more than your original plan, you have to disclose that, right? So don't hide anything. Don't ever hide anything. That is one of the autonomy things. Next thing, clinical research. So this is relevant to the job I do. Physicians are obligated to inform patients considering involvement in the clinical research protocol about the purpose of the research study and the entire study design, as it will affect the patient's treatment. This includes the possible risks, benefits, and alternatives to the research protocol. An informed consent form approved by the Overseeing Research Institutional Review Board (IRB) must be completed for participation in any clinical research protocol. Newly deceased patients may be used for training healthcare providers. The physician must obtain permission from the family or patient prior to death, and training must occur as part of a structured training program. So this I actually saw a question for in CK. I think it was in New World, I can't remember. But basically, you get a question, a patient came in, they have some kind of disease, you were trying to treat it, and then they died. And you have a student in the room with you. Are you allowed to now go ahead and use this dead body for any kind of medical practice? Maybe the student wanted to try out some kind of, or get better at trying to do some kind of surgical procedure. Can he try that now on this dead body? It is not unethical. It is not unethical to use a newly deceased patient for health training, as long as a doctor is watching. So it's not just, go ahead and rip it apart. So someone professional has to be attending there as well. And on top of that, some level of permission has been obtained, either from the family or the patient before they died, right? So if a patient is near death, you can ask them, all right, so now you're about to die. You're gonna die maybe by tomorrow. After you die, is it all right if we use your body for health training purposes? And then he can give permission for that, right? So it is not unethical. Don't get too emotional in picking the correct answer choice and then start thinking, oh no, he just died and now you're going to use his body to train. That doesn't make sense. It's okay. There's nothing to not make sense there. And if the patient is okay with it, then you can do that. Also, if the patient's family is okay with it, then you can do that. Now, if the patient's okay with it, but the patient's family is not okay with it, that doesn't override, because the patient already said he's okay. So first, is the patient okay with it? If the patient was never asked, then you ask the parents. I mean, the family. All right. So that's a very important little thing that they put here sneakily. It's just one liner, but this is an entire question on itself. On top of that, clinical research in general, when you have a patient that comes in and there's a clinical research your institution is running that might actually benefit this patient, you have to teach them about it. And this is a very difficult process, because this consent, this informed consent, takes a lot longer than usual informed consents about just doing any procedure. Because now you have to tell them how the study is going to work, how many times they have to come in, what they have to do every time they come in, what lab tests you're going to run on them every time they come in, how much blood you're going to take, etc., right? A clinical trial has many steps to it, especially a prospective clinical research trial, right? Where you're going to have to come back over and over. We're going to keep taking your blood. We're going to keep monitoring you. We're going to keep doing X, Y, and Z. And some patients might not be okay with that. So at that point, they would not sign up for that clinical trial. A lot of patients usually sign up for a clinical trial simply because it's free, right? So they get the treatment for free, and everything they have to do is free. So they prefer that over the alternative, which might be way too expensive and not covered by their insurance. This is what I do as well. So my department is the head, neck, and thoracic cancer, right? And that's the research facility I work with at Montefiore Hospital. And most of my patients that come in, they're all patients that have lung cancer that has probably metastasized somewhere. And at this point, there's not really any treatment out there that would benefit them anymore. Or if there is treatment out there, it would be too expensive for them. And most of these people are middle to lower class individuals who, especially in this time of a pandemic, don't have money to treat themselves. So they sign up for these clinical trials. They get the free treatment out of their free will. They want to do it. And they have to keep coming back to get monitored, right? So it's a little bit of a hassle for them, but it's a good trade-off because it's completely free, and oftentimes the medication ends up working really well. It's very rare that someone starts in a clinical trial and nothing happens, right? Here they talk about overriding confidentiality, so let's talk about confidentiality first and see what's up. Confidentiality, huge deal, right? Everyone wants their information protected. Big companies are investing millions and millions of dollars to protect your privacy, protect your confidentiality. Information disclosed by a patient to his or her physician and information about a patient's medical condition are strictly confidential and should be discussed and accessed only by those directly involved in the patient's care, with very few exceptions, which we're going to see. So if there's another doctor that sees you, right, this is a UWorld question as well, like you're at a dinner or something, some kind of medical conference, and another doctor comes up to you and goes like, oh, yo, I saw that Amir was coming out of your clinic yesterday. What's wrong with him? Well, it just so happens that this other doctor knows who Amir is, but I can't tell that doctor anything about Amir. You know, I can't even acknowledge that, yes, it was Amir that came out of my clinic. You know, so you would have to pick the answer choice that gives the least information away. And the best answer choice, theoretically, you know, it's not very practical, but, you know, even then you would have to do it. The best answer choice would just be to say, oh, I can't talk about that. You know, that's it. So very easy to do that. And, you know, it might be hard at first, but once you do it, it's very easy to do that. I can't talk about that. That's it. A patient may waive the obligation of the physician to protect confidentiality with insurance companies, authorized family members, preferably by way of written or verbal consent. The physician should disclose only the minimally necessary information. So don't give away any information. You know, you can't be like, oh yeah, Amir was there, but I can't tell you what happened. Or yeah, Amir is one of my patients, but I can't really share any details. You know, don't acknowledge anything. I can't talk about that. Done. I didn't tell the person anything now. I didn't confirm that Amir was my patient. Didn't confirm that Amir needed help. None of that, right? That's it. It is ethically and legally necessary to override confidentiality in the following situations. Patient's intent to commit a violent crime. Right, this is the Tarasov decision that was made in court. This required a court order to pass this. Physicians have a duty to protect the intended victim through reasonable means. Warn the victim, notify the police, right? So if there's a patient who might have a psychiatric illness and he's about to go home and maybe kill his wife or something, you immediately call the cops and you tell the wife, all right? Suicidal patients, again, you get rid of their confidentiality now. If they're suicidal, you have to keep them and you have to treat them, right? And you let the cops know. Child abuse or elder abuse or any child neglect, elder neglect, you have to report that to the cops, right? This one is going to be CPS, Child Protective Services. This one is just going to be the police, right? None of this is acceptable. This is also just crime, basically, right? So all of these are crimes. These are all basically crimes so far. Then you have your reportable diseases, which we talked about, right? Anyone with a reportable disease is not confidential information anymore because it doesn't just concern them. If you have one of these diseases, you're going to spread it to people. So duty to warn public officials and identifiable people at risk. It is normally best to encourage patients themselves to inform sexual contacts who are at risk for contracting the illness, right? But even if you encourage patients to tell everyone by themselves, you still have to report it. It doesn't matter if the patient is hiding it. So I always remember this because in one of my clinical trials, I had a patient who had HIV and everyone knew. It was not confidential information, right? Him having HIV is something everyone knew. You don't hide that, and that's it. Right? Gunshot and knife wounds. Duty to notify the police. If a patient comes into you and it's very clear they have a gunshot, right? And they tell you, maybe the patient might be like, oh yeah, I was playing with my own gun and I have a license, but then the gun went off and I shot myself in the thigh or leg or something. Please treat me. Sure, you treat them, but you still let the cops know, hey, this guy has a gunshot on his leg. He says it was himself that did it, but I just want to make sure that it was himself that did it and not that maybe someone attacked him or you guys attacked him. So if he's a criminal, he needs to be checked, right? So gunshot and knife wounds, you always notify the police. The patient is a danger to others. Impaired automobile drivers or anything else. Currently, only 6 states have mandatory physician reporting laws. A patient begins to drive 1 week after hospitalization for seizures. Although the Department of Motor Vehicles in his state requires that licensed drivers be without seizures for at least 3 months. Right? So if something like this is happening, where of course now he can go kill somebody because he's driving and he might have a seizure while driving, then yeah, you have to report that. Okay, so all these reportable things, right? Wait a sec before letting a dangerous patient go, right? Wounds, automobile driving impairment, infectious disease, the Tarasov and trafficking, human trafficking, suicides, elder abuse and neglect, and child abuse and neglect. All right. So guiding principles for overriding confidentiality. There is an identifiable third party at risk for harm. The harm is significant. The harm is significant and probable. Disclosure will help prevent or mitigate the harm, and other measures such as convincing the patient to self-disclose have failed. Right? These are the 4 main things you should think of before you get rid of their confidentiality. Right? There's no point in getting rid of somebody's confidentiality if you're not going to achieve some or at least one of these 4 dots. Okay? Mandatory reporting of intimate partner violence is controversial and varies by state. Nonetheless, physicians should document the encounter, offer support, and have resources available for assistance. I mean, that's something that happens, like take a look at this question. So this one says a 35-year-old woman visits a primary care physician after hurting her wrist. Physical exam reveals circumferential bruises of her wrist, neck, and arms. The patient admits that the injuries were inflicted by her husband. What is the most appropriate next step in management? A man beating his wife is something that does happen, right? As much as it probably shouldn't happen, it does happen. The other way also happens. There are women who are very abusive towards their husband as well. All kinds of things happen, right? Both case scenarios are plausible case scenarios that happen. When they do, the number one thing that matters is that individual safe? So in this question, when this patient came to me, it's very clear and she admits to it that her husband beat her. All I can do is ask her, are you safe in the house? Okay, are you safe in the house? Does she have kids? Are they safe in the house? Does she have a plan if he gets so bad that he's about to kill her? Right? These are the things that UWorld questions teach you, and you have to carry this out correctly. So let's see what they said here. They said, Offer support and acknowledge the courage it takes to discuss abuse. Assess the safety of the woman and of any children involved. Introduce the concept of an emergency plan should things get really, really bad. And encourage the use of community resources. If the patient consents, report the abuse to relevant authorities. Now, in your STEP exam, you might have a question where a patient came in telling you that her husband is beating her. You can't just go ahead and report that. That is not something you just go ahead and report. In fact, if you are from a country where this is common, then, you know, me being from India, I've definitely seen that, right? There are women who firmly believe that it actually is her husband's job to beat her. So at that point, reporting any of this would have been really bad for me, right? So I can't report this. I can't report this if the wife herself is actually okay with it. She just needs treatment of the beating, right? So then I'm just going to treat her, make sure everything's okay, that she's not going to die or bleed to death or anything like that. And if she has pain, get rid of the pain. But then that's it. Then she goes home. It's their business. Unless she needs help, don't give help. So if she only needs help with her treatment, then treat her, right? If she says that she needs authorities, she needs police help, then you go ahead and tell the cops, right? And then whatever happens from there will happen. Right, so very important to watch out for that. Getting rid of confidentiality is a very critical thing, and following these 4 guidelines to make sure at least one of these things is achieved is very critical. If you got rid of confidentiality and no one of these 4 things were achievable, then you got rid of confidentiality for no reason whatsoever. And at that point, you can actually face a court problem where the patient might try to sue you for not respecting their confidentiality. Right, it's a very critical thing. So the best thing to do often is just to stay quiet. Don't answer any questions to anyone if they don't have anything to do with your patient. All right, so that's it for now. In the next video, we'll wrap things up with conflict of interest and malpractice, and then a bunch of practice questions to see what's happening and how to tackle all of this. Thanks a lot for joining, guys. Keep it up. See you guys again soon.